Hello. Hello, everyone. This is Kathy Brown. I'm the Program Director for the Myasthenia Gravis Foundation of America, and I'd like to welcome you to Thymectomy or Not with our distinguished speaker, Dr. Gil Wolf. Dr. Wolf is Stephen and Rosemary Smith Professor and Chairman of the Department of Neurology at the University of Buffalo, Jacobs School of Medicine and Biomedical Sciences at SUNY. Dr. Wolf, it's all yours.
Well, great, Kathy, and thanks for inviting me to do this. Good afternoon to everybody, even for those on the West Coast, just barely so, I believe. So I was asked to go over the results of the recently published thymectomy trial in non-thymomatous myasthenia gravis. And at least the preliminary results, and we still have other data that we're mining, were published in the New England Journal in August. Before I go on, first of all, thank you for joining us, but I also need to thank a number of entities, and that includes the MGFA and the MDA. Both of those organizations provided us seed money, preliminary money when we were planning the study. The main funding was provided by the NINDS, and the trial could not have happened without that funding agency. I also just want to thank all of our patients and all of our investigators and put out a specific thanks to two of our leading investigators who passed away during the course of the study. That was John Newsom Davis, who really was the engine behind getting this done, getting it started, and Dr. Fred Jaretsky, who was our surgical chair for the trial as well, and really helped us envelop the community of thoracic surgeons in being able to accomplish the trial. So the other thing, and we discussed this in the planning stages last week for this webinar, if you have questions, I'm happy to try to answer them even during the formal talk, which really should only take about 15 to 20 minutes. So if something doesn't make sense, please do stop me, and I'll try as best as I can to address that. And by the way, I think you can all see the slides. These are pictures of Buffalo, which sometimes doesn't look so bad, and this is the new medical building here. Okay, so the next
I'm just going to, Dr. Wolf, I'm going to just interrupt for a second and say, so in order to get your questions up, please type in the box that is all the way down on the right side, and then hit the little bubble, the little cartoon bubble, and then your question will appear on the screen. Sorry about that.
Oh, no problem, and I see that window. And so interruptions like that do not bother me. I can get right back on track. And here is just a listing of numerous people who were involved with the executive committee, and I mentioned Dr. Newsom Davis, and that's his picture there. He passed away in 2007, and at the bottom left is Dr. Fred Jaretsky, our surgical chair, and Dr. Sana took over that role after Fred passed away. The next slide. So just as a quick background, there was a consensus in favor of performing thymectomy even in myasthenia gravis patients who did not have a thymoma. The thymoma is the usually benign neoplasm, benign tumor that rests under your breastplate, and that is seen in 20% or so of myasthenics. In such cases, the standard is to always remove that growth. It can create problems with further growth. It's a kind of priced real estate area of the human body. In the setting of non-thymomatous MG, again, there was a consensus in favor of doing it based on case series that were not randomized, and most of them were retrospective, meaning looking backwards as opposed to prospective studies. Numerous calls for many decades, starting in the 70s, perhaps even before that, to actually do a randomized control study in non-thymomatous myasthenia gravis for thymectomy, and there actually were some attempts, as you can see at the bottom of the slide here, in the 60s, 80s, and early 90s to actually conduct such a trial. I'm moving to the next slide now. So what were our aims? We really wanted to answer three questions in this population of myasthenia gravis. Compared to a prednisone protocol alone, where where patients were only receiving oral medications. Does performance of an extended transsternal thymectomy, and that does mean the type of thymectomy where a sternotomy, where a splitting of the breastbone of the sternum is required, does that procedure, in addition to prednisone, compared to prednisone alone, result in a greater improvement in strength? And that was based on this quantitative MG score. Did it lower prednisone requirements based on a time-weighted average prednisone dose? And did it enhance quality of life? And really, if we hit a positive response, a favorable response with any of these measures, especially the first two, we would consider the trial to have been a success. Why was there sort of this multiple outcome in the trial? It was because of the potential for both groups of patients to improve. We knew that patients on prednisone tend to do quite well with myasthenia gravis. Robert Pascuzzi and others had shown that over the years. So, since everybody was getting medical therapy, we were worried that maybe we would not see a separation based on outcome of the disease itself. So we also wanted to add that requirement of looking at prednisone needs in the groups as well. If the thymectomy perhaps would reduce the requirements for prednisone. I hope that makes sense. Before we ever recruited the first patient in the trial, we actually asked the investigators to predict what we might find. And what you can see here is 77 out of the 133 investigators who were surveyed did feel that the outcome would favor the use of thymectomy. But then again, that means that there was a sizable minority who did not feel that way. Some did not think that thymectomy would lead to a more favorable outcome. That was 27, and 29, so if you add those two together, nearly 60 of this 133 either did not feel like thymectomy would help or really just did not know. So there was what we call equipoise. There was a differing opinion or inferences of what we might find, and that's what you really like, you want to see when you're actually doing a clinical trial. And by the way, this data was sealed until the very last outcome was taken on the very last patient recruited into the trial, which was somewhere in late 2015, by the way. So the framework of the study, this involved a lot of sites, 67 sites in all continents except for Antarctica. We only recruited receptor antibody positive myasthenia gravis patients, and I hope most of you who are listening do know what your antibody status is. It's an important piece of information you should know. The patients were between age 18 and 65. They could have disease duration no longer than 5 years. There's reasons for that if you look at the old literature on why we had some age restrictions and disease duration restrictions. And compared to most clinical trials, this one was quite different because outside of the first basically couple of weeks of the trial, everything was the same for all patients. The difference was up front. Some patients got a thymectomy and some patients did not. ETTX here stands for extended transsternal thymectomy. The dosing strategy in both groups with prednisone was the same. And so once patients reached a minimal manifestation status, which basically means patients can do everything that they want, although on examination, a good neuromuscular neurologist may pick up some touches of weakness in certain muscles, but otherwise, the patient is really doing fine. So once patients hit that minimal manifestation status, we would taper the prednisone according to a fixed schedule. If the disease got worse, then we would ask that the prednisone be increased. So there were very strict criteria for how prednisone was dosed during the study, and then we had these outcome measures, and I've already mentioned the ones that are in yellow here, which were the primary outcomes. I won't mention the secondary outcomes now because we'll go through those when we get to the results in just a couple more slides. And this is how the randomization worked, and I hope this can be seen to some degree, but there were 126 patients ultimately who were randomized. And we had 60 in the prednisone-only group and 66 in the thymectomy plus prednisone group. A good number of patients. We actually were hoping for a few more, 150, but the recruitment process took longer than we had hoped, and funding was going to end. So this is where we finished, and we had hoped at a minimum we'd get 125, and we were able to get to that level, to 126. Just so you know, this was performed under an intent to treat analysis. So, humans change their minds. It's the way we are. And so some patients who were randomized to one arm really wanted to be in the other arm. Fortunately, we ended up with 8, basically, with either situation. So that kind of evened out. But that's the way trials are analyzed, at least formally in the best trials. It's an intent to treat analysis. What were the main reasons that patients refused to be in the trial? Those who were eligible, some really wanted a thymectomy, some really did not want a thymectomy. That's fair. Patients are allowed to make decisions about how they're going to be managed. Another major reason for refusing is some patients really did not want to be on corticosteroids. But in the end, more than half of patients, just over half, who were eligible for this trial based on entry criteria did agree to be randomized. We were glad to see that. Our actual projections on that before the trial was done was that about half of patients would agree to do it. Realize, patients were randomized to surgery or not. They did not control that. A computer basically did. It's a tough thing for patients to agree to do. As you can imagine, this is a major surgical procedure. What did our randomized groups look like? I'm going to go back a couple slides because I got a little bit finger on the arrows. But most of the patients, if you look in the top red line there, the top red row, most of them were female, not unexpected. Most of them were on corticosteroids when they went into the study. You could either go into the study without corticosteroids having been introduced or with them having been introduced in the past to manage the myasthenia gravis. So 3/4 basically in both groups, the prednisone alone and the thymectomy plus prednisone, ended up being on corticosteroids to begin with. And the median age was in the low 30s. So the typical patient, but not all patients obviously, but the typical patient was a younger woman. The median disease duration, as you can see here, although we did allow it to go up to 5 years, sort of the average was about 1 year, just a little bit more than that in both groups. And the average on this quantitative MG score was about 12 points. 0 is perfectly normal, by the way, on that scale. And it goes from 0 to 39. The typical prednisone dosing was about 40 milligrams, by the way. Pretty high dose, pretty high requirements that these patients were on to control their disease. On the next slide, you will see the first results of what we found from the interventions themselves. And this is the quantitative myasthenia gravis score. And the higher the score, which would be up here on the y-axis, this is the higher score, the higher the score, the worse the disease status is. And what you can see here in blue, and this is going to follow through with the next graph that I showed you, in blue is the prednisone alone group, in red is the thymectomy plus prednisone group, and what you can see here is there was separation. And it occurred fairly early on, but for the first year, as you can see here, we were starting to see an impact on the favorable side for thymectomy as far as this disease outcome score, the quantitative MG score, is concerned. And it persisted for the 3 years. All the patients were followed for at least 3 years. Some were followed actually even longer than that. And I just want to point out, this was single-blinded. The people who were actually calculating the quantitative MG scores, compiling prednisone dosing and so forth, were blinded to whether the patient had a thymectomy or not. How did we hide that? Patients wore these high-collar jerseys that were actually provided and had the insignia of the trial, MGTX, on the actual jersey. On the next slide, you'll see what happened with the prednisone dosing. And again, in red, it's showing a favorable effect of thymectomy on the prednisone requirements that, again, separated fairly early on and persisted for the 3 years of the trial. And here you can see p-values, and if some of you may know that a p-value less than 0.05 is considered statistically significant. We met that requirement to actually another order of magnitude at the 0.001 level. Here is a bunch of other outcomes. I've already introduced to you the results of the QMG, the quantitative MG, and the prednisone dosing, which is basically reflected here in these first 2 rows. But some other things, we did not have a lot, as I mentioned before, prednisone-naive patients. we could not really show in the prednisone-naive population here and here that there was a significant impact of thymectomy. We think that is mostly due to the small numbers of patients in those groups that we had available to randomize. But whether you're looking at the QMG score or the prednisone dosing evaluations, we could see positive impacts even in patients who are above age 40 and those who were men. In red here are the significant p-values that you can see here. On the next slide are a bunch of secondary outcome measures. So this included dosing, modeling, and adjustments that we made if patients had to, for instance, end up on azathioprine at year 1. We did allow at year 1 or afterwards, if patients had not met minimal manifestation status criteria or were having significant side effects from the prednisone, we did allow azathioprine to be introduced. If azathioprine could not be tolerated, other agents like cyclosporine could be used, but that rarely happened. But the azathioprine was used in a good number of patients, and I'll get to that in just a second. But with that dosing adjustment, sort of a penalty if patients needed azathioprine, again, we saw a significant favorable impact of the thymectomy. The myasthenia gravis activities of daily living also showed a favorable response for the thymectomy plus prednisone group. Again, here with a significant p-value. Azathioprine requirements were significantly less common if you had a thymectomy, 48% on prednisone alone versus basically a third that if you did undergo the thymectomy. IVIG usage was less as well. The minimal manifestation status proportions were favored, again, the thymectomy group. It was more likely to hit that at different time points, month 12, 24, 36, if you had the thymectomy than if you were on prednisone alone, again, reflecting these significant p-values. I only put in red at month 36, which was at the end of the trial, at that 3-year outcome. And then hospitalizations for MG exacerbations, whether you're looking at months 0 to 24 or the entire 3 years of follow-up, again, favorably showed a favorable impact of the thymectomy as far as fewer requirements for hospitalization in patients. On this last kind of heavy data slide that I'm going to show you, adverse events, again, thymectomy reduced the number of events significantly. It also reduced life-threatening types of complications. Thymectomy reduced that. Hospitalizations, as I mentioned before, whether for MG exacerbations or other things, also were significantly less as well in patients who received thymectomy. And so these were all things that kind of fell in line and really did basically prove that thymectomy, on a number of different criteria and domains, thymectomy did have a favorable impact for patients. Excuse me just one second. Okay. And so here's the summary slide, and then I'd be happy to take questions. And I'm looking in my chat box. I don't see any questions yet, but hopefully there will be some either in the chat box or if people call in with the questions. So the summary is we provided Class 1 evidence. You know, Class 1 evidence has a certain number of requirements, and part of that is the number of dropouts in the trial, and we actually had fewer than 15% dropout rate, which is sort of the standard for Class 1 evidence. But what we were able to show is that extended transdermal thymectomy has favorable impacts on receptor antibody-positive generalized myasthenia gravis based on clinical outcomes, and I showed you the quantitative myasthenia gravis data, as well as MG activities of daily living, the MG-ADL data, corticosteroid exposure, so again, a lesser need for prednisone. It was reduced by about a third, the prednisone requirements. Not quite half, but by about a third. And then fewer adverse events were seen as well in the thymectomy group. The impact can be seen earlier than 2 years and might be present at a 6 to even 12-month period of time after the procedure. And here's just a point about future investigations. We're still mining the data, and right now we're working vigorously to look at correlations between what we saw on the thymus. Remember, we have thymic specimens from a good number of patients, and this is being analyzed by our colleague, Dr. Alex Marks, who is one of the world's experts in thymic histology, in what the thymus looks like under the microscope. And so we're going to be correlating the changes we saw histologically from the thymus specimens and looking at those patients and seeing how well they responded to thymectomy. So just for instance, at a basic level, if the presence of a hyperplastic thymus, where you see all this follicular change with these follicles that should not be there, that we see in many MG patients, if the presence of that and if grading that has a certain correlation with the response to a thymectomy or not. For instance, with patients who don't have those changes, who have what's just an atrophic thymus, which was about a third of the patients in the trial, if they don't respond as well, we just don't really know, and we're going to try to figure that out as best we can with the data that we have available. And then there's a variety of bio-MG studies which are looking at profiles of protein analysis and gene analysis that many but not all the patients agree to do. That's being looked at as well, seeing if that correlates with responses to anything from thymectomy to even steroids. And with that, I'm done with the formal presentation. Here is the many thanks. Again, I mentioned this before. This was the group of investigators, by the way, in the upper left in San Francisco in 2006, and in the bottom right in Oxford in England. We had investigators from all over the world, and so we had 2 investigator meetings to make the travel requirements as easy as possible. And again, without the patients and our funding agencies and our close colleagues at the National Institutes of Health, that all our federal tax money, all of us put in federal taxes each year, and this helps fund, obviously, the NIH. We could not have done this without their support. Also, the DSMB, that's the Data Safety Monitoring Board, and there were neurologists and surgeons and others who were involved with making sure we were doing the right thing and looking at data that we were blinded to, but looking at data during the course of really what was a 9-year project from the first randomized patient to the end. They were looking at things to make sure we didn't need to stop the study early, to make sure we were being as ethical as possible. We need to thank all of them. And thank all of you in the MG community for supporting us. And I'm happy to try to answer questions now. So, can I start? Kathy, is that okay? I see one typed in here.
Yeah, absolutely. There's several there.
If the thymus is not bad, does it help to have it taken out? And I assume there it means that the thymus neither shows a thymoma, so neither a neoplasm, or is not hyperplastic, is not enlarged. And both of those findings you can see on a chest scan, a CT or an MRI of your chest. I can't answer that question yet. Again, that's one thing that we're looking at right now. We will try to find out if the absence of histologic changes, such as hyperplasia in the thymus, if the absence of that means you won't respond to thymectomy. I just don't know. It's possible that you will still respond to thymectomy. We're going to try to decipher that as best as possible. Okay. There are a bunch of these.
I'm going to suggest, Dr. Wolf, I just want to suggest that you scroll all the way up because there's quite a few, use that little scroll button and go all the way to the top.
All right, let me get up there. All right. I got it now. Okay, it was hiding. Okay. Were all thymectomies transsternal? Iona Toth sent this one in. Were all thymectomies transsternal, open chest? Yes, they all were open chest. They were not robotic. Da Vinci is one of the robotic devices, I think the most common one used around the world. No, we did not do that. These were extended transsternal thymectomies. It begs the question what the results would be with less invasive thymectomies. The point I think I can as accurately make as possible, since we did not test these other surgical techniques, if the surgeon's intention is to remove as much thymus as possible and really take the time to do so, we would conjecture similar benefits would result. And to be honest, most of our sites do less invasive procedures the majority of the time nowadays. I know mine does. So these were techniques that were just coming into play as we were designing the study in the late 1990s, early 2000s. But they are uniformly done in many industrialized countries now. And so the intention should be to get as much thymus out as possible. I'm moving on. Dr. Barron wrote, how long are you now telling patients it takes to see an effective thymectomy if they're going to have one based on the study? Well, I tell them, I don't know for sure, but it's possible within the first year you may be noticing benefit from the standpoint of better disease control in our ability to get you off medications more easily than we could in the past if the patient had been treated for, say, a few years and had struggled with tapering of immunosuppressive medication. I tell them that. Now, it's only been a couple of instances because this scenario doesn't come up every single day in the clinic. It comes up every month or so. But that's what I tell them. I tell them that possibly in the first year, although it's not guaranteed, possibly in the first year, we may be able to start removing medications at a faster and more successful rate. Maybe not so much faster, but in a more successful pattern than we could in the past before the thymectomy. Okay. I read somewhere that even in adults, the thymus gland is responsible for maintaining the T cells. Is that correct? Yes. The T cells are named T cells because they originate and mature in the thymus and learn there. They're basically educated, and that's their school. Now, I'm not an immunologist, but the best way I can describe the thymus, it's the school for T cells, where they learn to recognize self and be able to distinguish self so you don't attack yourself versus outside threats such as organisms, toxins, and so forth. So yes, the thymus remains important even into adulthood. Now, as you get older, it tends to involute, and it's possible by that point in time we've educated ourselves quite a bit as far as how our T cells, our immune cells, are supposed to react. But yes, it is correct that the thymus is still maintaining T cells even in adult populations, at least through young to middle adulthood. If you no longer take steroids and are taking CellStuff, does that still fall under this study? Great question. All right. We only entered patients who immunosuppression history was corticosteroids. Now, if they had taken a non-corticosteroid remotely in the past, or were currently on a very low dose, and that did happen a couple of times, like, say, azathioprine 50 milligrams a day, which is a very low dose. If they stopped it, we would let those patients in the study. But otherwise, patients went in only on corticosteroids or no corticosteroids alone. We thought about changing that during the course of the study and widening the entry criteria, but we decided that it really would pollute our interpretation of the results. So we held firm on that. The only immunosuppression that patients could be taking at a therapeutic dose, basically, and that did not have to be stopped before entering the trial, was corticosteroids. So a patient on CellStuff would not have been allowed. Now, the other aspect of this question, if you're still taking CellStuff and you're still struggling from myasthenia gravis and you're receptor antibody positive, I would encourage the use of thymectomy. Why would you not? Possibly if the patient's had a disease duration for many, many years, but even in that case, it could be considered. But if a patient is still struggling and having difficulty despite therapeutic doses of CellStuff, I think thymectomy is a very reasonable option if that patient is receptor antibody positive. Okay. I already answered that. Next question. Do you recommend thymectomy for someone who is receptor antibody positive, generalized MG, but 10 years since onset? Again, I kind of touched on that just a moment ago. Look, if the patient is doing well, and most patients with MG are doing well 10 years after onset. Not all, but most are doing pretty well. If they're doing well, I don't think you need to consider thymectomy. If the patient's been stable for 2 or 3 years on reasonable, fairly low doses of immunosuppressant medication, not having significant side effects, I don't see a role clearly for thymectomy in that setting. But if those criteria are not met, then yes, I think thymectomy is reasonable to consider, although we can't really address that 10 years with 10 years of disease duration. And I'm not sure any trial will ever be able to do that, but I still think it's a reasonable option. I just don't have direct evidence to support that. But I had a thymectomy. They went in under the breastbone, very small scarring. I'm not sure if this is if this is meant to be the incisions that now are very, very small, but still through that small incision they do a complete sternotomy, or if this is a VATS procedure where they go through thoracoscopically from the side and actually end up down right underneath the breastplate. But yes, you can have minimal scarring with either approach. I've seen very, very small scars compared to those I used to see 10 to 20 years ago, despite a transsternal procedure. And so they're able to get the scars sort of below the neckline with lower cut blouses and so forth, especially for women, so the cosmesis is much more favorable. But I'm not exactly sure what was meant there. If it's from the side, those are very, very small, almost punctate little incisions where they then put in the scope. So it's really just a small hole, like the size of a hole. I'm trying to think of something. Oh, like maybe the size of those things that you can look through the door. Around that size, if you take the whole diameter when you're looking through the door to see if it's somebody you should answer the door for or not. Something of that nature. Okay. Lots of questions. This is great. Patient age 39, woman, had thymoma removed transsternally at age 9. 2 years later was diagnosed with MG. Yeah, that can happen. You can actually develop MG after the thymoma is removed. And just so you know, so this is kind of the reverse situation. It is something like 40 to 50% of patients who have thymoma who either right then have myasthenia gravis or eventually will develop myasthenia gravis. So it's quite common, 40 to 50%. Surgeon removed the thymoma but did not do a complete thymectomy. Should she consider redoing the thymectomy? MRI and CT currently inconclusive. What's the, well, so here again, it's to the point of how that individual is doing clinically. If they're doing very well, there is no reason to re-entertain another thymic procedure. If they're struggling, then it's something to consider. Now, I've seen patients who've had a thymectomy, whether there was a thymoma or not, previously, and they're struggling. And sure enough, in some of those patients, not many, this is only a handful of patients that I've seen in my basically 20 years, but in some of them, the CT or the MRI shows evidence of residual thymic tissue. In this case, that doesn't seem to be present, but you'll see residual thymic tissue in those patients who often have not behaved to therapy as well as you might think. And in those cases, when you go in and do a thymectomy and get out that residual tissue that you saw under the radiological studies, the patients end up doing quite a bit better. And so, but that doesn't seem to be exactly the case here, where they are not seeing clear evidence of thymic tissue. But again, if the patient is not doing well clinically, thymectomy is something to consider. If the patient is doing well after this resection, why really would you do it? Okay.
Gil, this is Kathy. Your camera is fogged up. You might want to just give it a little wipe, see if that clears it.
Okay, or maybe it's because it's getting dark in Buffalo.
That's better.
All right.
That's definitely better.
At the camera. Okay. Dr. Barron just agrees with my comments, I think, about when patients may start seeing a response to thymectomy. Okay. More questions. Oh, good question. This is a great question. If the thymus is removed, how do we maintain T cells? Boy, I'm not sure I can answer that. All right. I'm not an immunologist. How do T cells continue to be trained without a thymus? Part of it is from memory. that's instilled upon them. And it's not like your T cells go away after a thymectomy. They still are present after a thymectomy. That is a question I really, and I'm not sure exactly what's meant by maintenance of T cells, but they're still there. And I really would need an immunologist to help me to answer that question. That's something really for an immunologist or a neurologist who has a bench career in basic immunology to answer. I just can't answer that one. Oh, the screen fogged up. I'll unfog it again. Okay. Do you think thymectomy effect will last longer after 3 years? Oh, okay. So we do have data beyond 3 years. I've gotten some preliminary views of that data. And we are planning to write a paper because we have some patients with data that goes out to 5, 6 years, actually, that remained single-blinded. It wasn't part of the formal analysis, but since the patients could continue to be followed, and this is mainly the patients who were recruited earlier on in the study, again, the recruitment phase of the study stretched from 2006 to 2012, 6 years. So some of those patients who were recruited early on, we kept getting a single-blinded data outside of the main data collection of the trial for a couple more years after that 3-year period of time. We're looking at that. How can I give you a preview of that? I haven't seen it all. We're still looking at that, and that's not our main focus. The main focus we want to do right now is the histopathologic correlation. All right. There is a chance, because most MG patients do well over time. They continue to get better over time, and the Japanese have shown this, as have other groups, that the curves that I showed you that were still separate at 3 years are going to start to converge. My argument, if they do converge, is this. Even if you only get a benefit at 5 years or 6 years, wouldn't the reduced hospitalizations and prednisone requirements and adverse events over even that 5 or 6 year period of time be worth it? I think that they would be worth it. I think they would even be cost effective in a cost analysis as well, but we'll have better answers of that later. But there is a possibility, given the fact that most patients with MG tend to do better over time, that you will see some convergence of those curves. Sorry, I need to go to something real quick. Okay, sorry. All right. Let me get rid of that. Fine. Okay. Next question. I am MG positive. I imagine that means antibody positive. Did you limit the test for patients only on prednisone or no other meds to control the variables? We limited patients to prednisone only as far as what immunosuppression they could be on when they went into the trial. And in fact, since prednisone is so widely used, even back in 2000, even before that, prednisone's been widely used in myasthenia gravis really since the 70s. So 3/4 again of our patients were on some prednisone dosing before they went into the trial. We would have liked to have recruited more patients and have had a larger number of patients who were prednisone naive, but it just didn't work out that way. Okay, and so that follow up further on that question. In other words, in my case, if taking CellCept and I participated, then that would be another variable. Oh yes, it would have been another variable to evaluate. And so that gets into what biostatisticians warn us about and so forth. What was the danger of allowing other immunosuppressant agents besides corticosteroids? We know that those agents, if they work, they tend to work after months of exposure. Patients may need to be on agents such as azathioprine or mycophenolate or methotrexate, for instance, for a year or longer to start getting a favorable impact. If that agent had been started, say within that period of time, a year, 6 months or whatever, before they got randomized, it could cloud, it could interfere with the interpretation of the results. So that was a prime reason why we didn't allow those patients in. Now, you could also look at it from the standpoint, all right, if you allow those drugs in, such as CellCept or cyclosporin or methotrexate, that hopefully with a large enough number of patients, there would be an equal number of patients in both arms who, say, got exposed to mycophenolate 6 months before they were enrolled. But the possibility was we wouldn't have been able to get that even distribution, and it really would have made it more difficult to interpret the findings of the study. All right. Oh, and the last point there was that because something like CellCept was impacting the immune system in a certain way, excuse me, that it would really have been dangerous for the patient to be enrolled. That was not the reason. That was not the reason they were excluded. It was for the reasons that I mentioned before. I've declined thymectomy. Oh, and there was one other point by that same individual on defining under control. What does under control mean in the study? And also, in the international treatment consensus statements that Don Sanders and I and Pushpa Narayanaswamy and a bunch of international colleagues put together, the outcome that is desirable in MG is minimal manifestation status or better, where the patient is not having significant adverse events from those management interventions that are being used to get patients to that status. So minimal manifestation status or better. What's better than minimal manifestation status? Basically two categories: pharmacological remission, which means the patient has no signs or symptoms of MG, but is still on some type of medication therapy, or complete stable remission, where the patient's been off all therapies for at least a year. All therapies includes, in the formal definition, pyridostigmine, by the way, mestinon, by the way. Those would be two even better outcomes than minimal manifestation status. But minimal manifestation status is considered good. Okay. I keep losing my spot. I have declined thymectomy 8 years ago at the onset of my MG, non-thymomatous, precisely because the data was inconclusive at the time. Oops, and I cannot get to that cursor now. Oh, here we go. Am hypersensitive to prednisone and refractory to virtually all typical immune suppressants. Get IVIG monthly and mestinon. Severely disabled, fully bedridden, BiPAP. Could it make sense for me to try thymectomy at this stage? I think absolutely. Especially if you're receptor antibody positive, and I'll add on, or double seronegative, so that you're not MuSK positive. It is definitely something to consider. If you're receptor antibody positive, you are really struggling, going through a lot of different medications that just are not doing the trick. What would the other options be if you want them? Rituximab, potentially. But I think thymectomy is something to consider. I really do in that setting. You're getting many medications. Many have not worked. You're needing IVIG on a regular basis. Yes, something to consider, no question. Okay, and continuing. Hold on, I need to step off one more time. Okay. Lots of questions. Currently, is there any evidence that the non-invasive procedure is as successful in removing all the thymic tissue as the transdermal approach? Yes, there is. It's done mostly, those papers are mostly in the surgical literature. I just reviewed one actually from a center in Europe. There are numerous studies that do suggest that lesser invasive methods of removing the thymus gland are as good as a transdermal procedure. That includes VATS procedures that are robotic or non-robotic. They seem to get the same amount of thymus out. It's when they weigh them. A typical weight of the thymus specimen removed, by the way, is about 75 grams, if you're wondering, 75 grams. All right, so they also have followed patients sometimes for 5 to 10 years, and they say outcomes are as good or even better than the extended transdermal approach. One thing that seems to be clear, the amount of time patients are in the hospital, their needs for pain medications are lesser with these minimally invasive techniques as opposed to an extended transdermal thymectomy. Again, when we were designing the study, we were in the context where these types of procedures were only coming into play in surgery departments. They were sometimes being used, but in only a few places, and we had the mission to show that in the first prospective randomized trial that thymectomy worked or didn't work, and we wanted to ensure that as complete an excision as possible was being done. If the study had been negative and we'd been using lesser invasive techniques that really had not been refined to that point, we would have been open to criticism that you should have done a more complete thymectomy, and we didn't want to cross that path and have that dilemma. And so that's why we held to our guns and required an extended transdermal thymectomy. At different points, a couple of points that I recall, we considered using lesser invasive techniques, allowing them in addition to extended transdermal, and we just decided there was too much risk involved to do that. Okay. Let me see. I want to make sure I didn't miss any. My experience with Imuran. And Imuran versus cyclosporin. That's a little bit beyond this, but quickly. I think both drugs work in myasthenia gravis. There's randomized studies that show that they both work. Cyclosporin is really hard to use long-term, meaning after 2 or 3 years. Hypertension and kidney issues seem to arise in a majority, I'm saying a majority of patients, and if you actually look at the studies that Dr. Tyndall did, you'll see that the majority of patients had to be withdrawn from cyclosporin after several years because of those side effects. So it's a tough drug to use. There's another drug which is in the same class of calcineurin inhibitors called tacrolimus or tacrolimus, depending on how you pronounce it, Tacrolimus. It's also known as Prograf, which is a trade name, also used to avoid transplant rejections like cyclosporin has been, which also may have a positive impact on MG and may be easier to use than cyclosporin. Imuran, you don't tend to have those issues with long-term tolerance that you do with cyclosporin, but I think both can work. Okay. Thank you. My receptor on average is around 45. I imagine their antibody level, which would be 45 nanomoles per liter. The only med not tried, Rituxan. Do not have much to lose, I guess. I can't remember the context, but right now, just so you know, there is a phase 2 trial that's NINDS supported looking at rituximab in receptor antibody positive patients. If you look, the vast majority of the evidence in these case series, which involve usually patients, 10, 12 patients or so, looks really quite good for rituximab, both in receptor antibody positive and MuSK antibody positive MG. But we'll have a better idea once that phase 2 study that's supported by the NIH and the NINDS, which is a branch of the NINDS, which is a branch of the NIH, when that will be completed, and that should be at the end of 2017, somewhere in that, at the end of next year, we should have results from that. Okay. Out of all the patients having thymectomies, how many thymectomies, how many thymectomies, I can't read that, that's a typo. Let me see. Oh, caused diaphragm, phrenic, vocal cord damage. We had only one issue with some speech change from the thymectomy that did improve. So it rarely happens. It was very, very unlikely to have that issue. Okay. And I think, let me go through again in the other direction. I think that's the last question. You guys kept me busy, which is fine, which is fine. All right. And if I didn't answer the questions correctly, you can type in something real quickly now, and I'll try to address it better. Thank you. Somebody just said great info. Thank you, Heather. And some more people are typing. How are we doing time-wise? Oh, good. 50 minutes. By the way, there is no snow in Buffalo at the moment. Oh, thanks for texting in. Great questions. These are great questions. These are as good questions as what we get from reviewers of our papers. These were great. Okay. Anything else? And I hope everybody could hear me. I usually have a voice that projects pretty well, but
yes, you were very, very clear.
Oh, good. And this is great. You know, I've never really answered questions in this chat type format like this. I've entered questions myself, but it's kind of interesting to go through it this way because it does take a little bit of time and to make sure you didn't overlook somebody. Okay, but a great system.
Good. I'm glad you liked it. Got a couple more people typing.
I'm going to put on the light. I'm moving for 1 second. Oh, I don't think that's any better. Let me defog my camera. Okay. What is the positive for the JC virus and using rituximab? All right. That's a tough question. You know, I don't know of data with rituximab and being positive for JC virus exposure. Now, we have an idea, my MS colleagues do, for multiple sclerosis patients who are getting Tysabri, which is a 300 milligram injection pretty much every month for bad MS. And the rate of developing the infection, which is a very bad infection, often, not always, basically, usually it's fatal. And we don't have any antiviral therapy to treat it, this viral infection. It's about 1 in 300 to 1 in 1,000 people who are positive for the JC virus who will develop progressive multifocal leukoencephalopathy, which is called PML for short because it's too long a word for too long a term for most people to say, PML. I don't know what that number is for rituximab. I don't want to scare people, but there is now a published report of PML in a myasthenia gravis patient who is getting rituximab to control their myasthenia gravis. It has happened. I've heard from a colleague who is aware of a second case that has not been published. I know that the case that was published was on numerous other medications. I do think if you're on multiple immunosuppressive agents and also on rituximab, your chance of getting PML, I do think, is quite a bit higher. Again, it's probably less than 1%, but it's there, and it's certainly something you don't want to get. That's why I think in most settings, when you're going to use rituximab, there should be an attempt to come off as many immunosuppressant medications as possible before you're put on rituximab. Now, what do? I usually don't want patients on anything more than corticosteroids. I can tell you that in the NN103 study, which is the aforementioned NeuroNext trial of rituximab, the phase 2 trial in myasthenia gravis, they are allowing patients in who are on other immunosuppressive medications, and so far I have not heard of any issues with PML in that patient group. So that's good because there are some 50 or so patients who have been recruited into that trial. Of course, these infections can occur quite a bit later, but so far, so good at least. But I don't know of a specific number, but it's going to be less than 1%. probably less than 0.1%. All right. Lots more questions. Okay. This is a relatively unfair question, but are you able to comment about the role of thymectomy in pediatric patients? Yeah, I'm going to say, look, I think thymectomy is very safe in young kids, adolescents through the younger teenagers. We recruited patients as young as 18, but there is data from Mayo Clinic, older data, thymectomy can be done in these younger populations, at least once they're in the adolescent age range, and be done safely and with a favorable effect. Okay. Did I miss one? No, that's the last one. 33 on methadone, Imuran, diagnosed 7 months ago, ocular only now, doing good now, thymectomy or not. All right. If you look at Dr. Barron and Dr. Gronseth's practice parameter from 2000, where they looked at the ocular signs from MG itself, they tended not to show that much of a benefit from thymectomy. All right. So you're a pure ocular now. I think the prednisone, and there is one study with azathioprine as well, and pure ocular suggests that that reduces your risk of generalizing over time, meaning having disease beyond just the eye musculature itself. So you're there. You're on Imuran. You're doing well. I assume you're receptor antibody positive or seronegative. I don't think you need to have a thymectomy. I'm going to say just keep doing what you're doing, but taper very slowly. And what do I mean by slowly? And if you look at the treatment recommendations that came out in the Green Journal, in the Neurology Journal in July, that Dr. Don Sanders is the first author on, changes in these immunosuppressive medications should really be slow, okay? Much slower than corticosteroids. We're talking about a dose reduction every 6 months or so. Just go slowly, take your time, you're doing well. If they're going to reduce the dose, say from 150 or 200 milligrams a day of azathioprine, which is what Imuran is, the reduction should be no more than 50 milligrams every 6 months or so, or slower. Okay. Let's see. It's really hard to see this. How can I expand this? I guess I can't. I'm reading your paper, but have not seen where you classify the MG in the patients. That is, was ND randomization given to folks with general? Okay, so there were equal numbers of patients in both groups, basically, who are MGFA class 2 through 4. That's mild generalized at class 2 to severe generalized at class 4, with moderate being class 3. They ended up being equally allocated. Most of the patients in the trial were class 2, which is typical of most MG studies. It's the milder generalized patients that end up getting randomized for whatever reason. But yes, we did record that in the paper, and you should be able to find that I think it's in the appendix, actually, of what the patients look like as far as their degree of generalized disease. Okay. Hold on, I need to leave just for a second. Okay. Okay, did I miss one? 33 must have. I think I got them all. Okay.
That was excellent. Thank you so much for taking the time to do this. We really do appreciate it. And thank you, everybody, for joining.
I appreciate your help and all your technical assistance and everybody's participation and all the questions. And have a great holiday season, everybody. And enjoy the winter weather.